will make this presentation in 4 points. What is very important to know is, as you know, Burkina Faso is located in West Africa, and our health indicators are very weak. And at the moment, the government and the Ministry of Health make a reflection and think it is very important to bring action in their work. And the question is how to better use community-based organization to meet the population needs. IPC is my organization, is a Burkina this NGO created in 1994. And we are also a leading organization of International HIV/AIDS Alliance. We have a contract with Ministry of Health for the East Central region, and we cover around 6 health districts and 17 primary health centers. And we try to collaborate. We don't try. We collaborate with the Central Isolation Health Center to introduce the social map. It is a planning, implementation, monitoring, and evaluation tool. And with this tool, we are able really to ensure that all social groups are taken into account. And at the same moment, we can have a real-time data on the population and on their health status. Our entry point is the household. The home is our entry point. And we have a register. And in this register, we keep all details of each identified household, including demographic and health data. And we try to update quarterly, taking in account any change, rebirth, death, or marriage, or visitors. And especially for health data, we target women and children. And we capture some information around consultation of healthy newborn, immunization group, and so on. And every month we have a meeting with, between community health workers and the health centers to show the progress, but also to make the planification. And every year we have a general meeting per village to share data and to see the evolution of the work in their village. What is the vision? Now we have social map for 512 villages, and we collect data from the social map and register for all these villages. And what is very important, these data are validated by the chief of the village, but also by the household. And we establish also a cause of childbirth preparation for women which has 5 months pregnancy. We have also guide on individualities in their group for pregnant women, postpartum, women who are not pregnant, for child. And we try to collect nutritional status of children, and we try also to put in place a reference between the health centers and the community. Just this to show the progress in the different villages. And what I want to say, the problem we found is that sometimes we create that what we are doing is in the Ministry of Health work. We are just doing this on their behalf. And it is not easy sometimes to bring the health centers, the agents in the local way to be part of our vision, because we are just an NGO. And this is to show also that we put a reference between the health centers and the community, and so that is work. In conclusion, what I want to say is that this approach to put a platform between CDOs, community and health center can work. But what is very important, and I want to share with you, is that at the end, it's become very clear that the community can be in control of their health. They can be in touch with the health center and can push the health center to take action in the community. Thank you.
Thank you, Lydia, for keeping time. You said that some 3 minutes, despite the language challenge. So we are going to the last but not least presentation, which is questioning whether or not the existing health information systems are able to help us track what we are doing in terms of integration. The speaker is Susan Adamchak. Yes. Susan Adamchak is a scientist, a sociologist, working in Health Services Research Unit at FHI 360, North Carolina, USA.
Jumbo. I'm going to say it again because I see a few people have not really responded. So, Jumbo. That's great. That's great. Thank you, and as the other speakers have welcomed you, I would like to add my gratitude as well that you're here with us today. Before I begin, I'd like to just acknowledge my 2 co-authors, who are Francis Okello, who is one of the Associate Directors for Strategic Information. He resides in Ethiopia and is involved in our Adamchak office there. And Dr. Inoussa, who is our former Director of Strategic Information and has recently joined UNICEF. So the question is, do these existing health information systems that we all work with provide an accurate picture of integrated family planning and HIV services? I think the reason we are all here at this conference is because we acknowledge the growing interest and importance of integrated services. But outside of these special studies, such as we learned this morning taking place in Inoussa here in Kenya, our monitoring systems have not really been adapted yet to consistently track and report on those integrated services. So I'd like to speak with you today about efforts that we undertook. So the rationale for doing this is increasingly programs for reproductive health, HIV, are adopting integrated service strategies. We know that this assessment of effectiveness is essential, but we lack standardized indicators that would allow us to measure what we're actually doing. If you remember this morning in Dr. Bijlo's presentation, he had several slides listing potential indicators, most of which have not really been put into practice, most of which are somewhat complex if you looked at them carefully, with multiple layers of information required in order to accurately determine the performance. I've seen many times in the health facilities that I've visited, and I'm sure you all have as well, that a lot of work that gets done doesn't get reported, and if it doesn't get reported, it can't be reported. So I think we would agree that if we had more information about what we would be able to engage, to look at our services, assess whether we're actually meeting the needs of the clients who come through our doors. Are we performing well? What do we need to do to change in order to offer high-quality services? So we argue that we do need some standardized indicators that would allow us to measure integrated family planning and HIV services. So the objectives of our study were to determine the feasibility of collecting data to calculate standardized indicators for the integration of family planning and HIV, to obtain the information we might need to refine the indicators. We did a lot of work ahead of time we looked at loads and loads of possibilities for our indicator set. We ultimately refined them to 6, which I'll talk to you about in a moment. But until we actually tried using them in the field, we didn't know if they were going to measure what we wanted them to measure. And then we wanted to look at what was going to be required in order to modify the existing health systems and health information systems in order to calculate those indicators. So I'm sure this is not an unusual picture or a strange picture for many of you as an example of a health information system. I'll come back to that in a minute. So the 6 indicators that we settled on are listed here. I want to sort of stave off any questions you might have later. Obviously, this is shorthand for a presentation like this. Each of these indicators has been more fully specified, more fully defined, according to common international standards of what's the numerator, what's the denominator, what's the periodicity of collection, etc., etc. But basically, we looked at 6 indicators that are looking at integration from both ways. We heard again this morning that we're not just talking about integrating family planning into HIV services, but also adding elements of HIV services into family planning. So our first most basic element is whether HIV service clients are screened for family planning needs. What is once they have been screened, what is the proportion that we have determined who have an unmet need for family planning? What is the proportion who receive a method or are referred for a method? We've heard a couple of times this morning about unmet need resulting in unintended pregnancies. So what are the proportion of continuing HIV clients, HIV service clients who report an unintended pregnancy? The flip side, as I mentioned, is who are the family planning, what proportion of family planning clients are being tested or referred for HIV testing. And then at a very fundamental level, what is the proportion of service delivery points in our system, be it a program monitored by a single NGO? Are we talking about the entire public health system? What is the proportion of service delivery points that indeed offer integrated services? So as mentioned, this is a feasibility study that was conducted to determine whether these indicators could be calculated using existing data. Right? There were no efforts made to introduce any new forms, no electronic record systems, we didn't train anybody. We wanted to know what was available within health systems that we might be able to use in order to calculate these indicators. It was carried out in the 5 countries you see noted here: Ethiopia, India, Rwanda, Tanzania, and Uganda. About 10 sites per country. The field work took place early last year. Data collection was done using a very basic cell-based data extraction form in order to review registers and reports. On that form, we recorded 12 values that were needed in order to calculate the numerators and denominators for those for the indicators. A 6th, that one for the proportion of service delivery points, was calculated at the program level. We also looked at the data sources that were available, and we reviewed every registers from every HIV service. So we looked at VCT registers, we looked at PRTCT services, we looked at ART registers, we looked at labor and delivery, we looked at antenatal care, family planning, anything that might have an element that we could use in this process. We also looked at client record cards to see if there was a place on that card where appropriate data elements were recorded. And then we looked at the completeness of the data, whether it could be disaggregated, etc. method were referred, whether family planning clients were tested or referred for testing, and the integrated service delivery points, i.e. that measure that was done at the program level. You'll see that number 4, unintended pregnancy, there's NAs all the way across there. Indeed, it would be much more appropriate to measure unintended pregnancies through a population-based survey, or through a survey, a deliberate survey of HIV clients. And we were not doing that. However, we did want to include it in this effort because we wanted to know what was happening at the level of the clinic, whether they themselves, the providers themselves, were acknowledging or had heard from the women they were seeing that that pregnancy had been unintended. The one caution that we observed was that when we asked providers this question, frequently they told us, go talk to the people in labor and delivery and they'll show you their registers. Well, the labor and delivery people aren't really recording whether that was an unintended pregnancy either. The underlying assumption is that all of the pregnancies to HIV positive women were unintended. And I think that's something that we need to keep in mind. We heard earlier about what we can do for safer pregnancies, safer fertility treatments for women with HIV. We need to be careful of those biases. So our recommendations about indicators to retain now are the proportion of service point delivery points that offer integrated services, the proportion of HIV positive women receiving the family planning method, and the proportion of women accessing family planning services who are tested for HIV. Now you may not remember, but in the initial slide that I showed you, those two latter indicators referred to clients. So we were looking to see if we could collect information on both men and women. Again, I think we have to acknowledge the reality that very, very few men access family planning services, and few men in HIV services are counseled on any kind of family planning other than condoms. That's not to say it shouldn't change in the future. That doesn't mean I'm not thoroughly a proponent of the engagement of men in reproductive health issues. The reality is, in terms of collecting data right now, this is what we're able to do. We are also recommending that a future indicator be the proportion of women accessing family planning services who are screened for unmet need. Now, several organizations right now are testing screening tools and measurement tools to get at a better conception of unmet need. Not at the population level, where most of us think about it as calculated from a demographic and health survey, but in the clinic level. So organizations like Pathfinder, ICAP, FHI, WHO are all trying to figure out ways to assess this at a programmatic level as opposed to the population level. So hopefully, when we have our next integration conference, we'll be able to report on some of that information. Very quickly, I just want to talk about some of the data challenges. Most care and treatment sites were unable to calculate their current client load. I think this is starting to change, but historically, because of the indicators that have been requested by donor organizations, HIV sites record the number of people enrolled in care. And that doesn't allow for people who have transferred out. It doesn't allow for people who have been lost to follow-up. It doesn't allow for people who have died. They may be able to determine that if they dig down, but virtually no place we went to could tell us what was your daily client load. How many people do you think you've seen in a month? The denominators for these indicators were very difficult to calculate sometimes, in part because of our use of longitudinal records in some of these programs. And in some cases, particularly in HIV services, but also sometimes in family planning services, clients on a daily basis are not recorded if they only come for resupply of their drugs or their family planning commodities. Oftentimes, multiple sites are recorded in the registers. If a lower one, and the previous person was 2 minutes extra, so she is 2 minutes here. Oftentimes, lower-level facilities, a health post will report up to a health center. So when we do try to assess the denominators, they're to not use a unique client identification number. Age was recorded in many different ways. So our conclusions are that current data do not, in fact, deliver a clear picture of what we are doing in integrated services. We do believe, based on our field visits to all these sites, that integration is starting to happen, but at a much lower level than we're able to convey to our donors, to our governments. And we think that data utility could be improved by employing unique client codes, by employing standardized formats to record age, by introducing service codes. I didn't realize prior to this exercise that frequently services will share a single register. So if you have a counseling and testing register, people may be coming into that, entered into that register because they've been referred from antenatal care, because they've been referred from family planning, because they've been referred from the outpatient department. And you can't determine looking at that register what was the originating service. And finally, we think it might be wise to separate out the data from multiple sources, side to side.
Thank you, Susan. Yes, I hope you're awake. Very much awake. Good. So, we are 15 minutes into tea break, which means we don't have tea. Yes, but we will do our best. So we'd like to open up the session for questions, discussions, comments. And since the morning I was sitting on the other side and I felt unfairly treated, I'll start from that side, coming this way. Yes, so kindly move around the microphones. Quickly say your name and your question and who you're directing the question to. There are no questions. Oh, 100. Or should I pick up what was discussed, since you may not remember? Okay, quick recap. The first discussion was about counseling on contraceptive options for serodiscordant couples. And I think what came out of that is that up to 50% of the couples desire children and should be given options to do so. The second presentation by Megan was on cervical cancer screening in HIV care services. And she noted that it's essential that it's important that this essential service is provided, but there's a need to address human resource gaps and equipment that are necessary for implementation. This is one point of care solution that we need to address, where we see, test, and treat. The third presentation was on scaling up evidence-based integration modeling in Tanzania. We started with a needs assessment. It's always important to document where you are. And what I had to give was a description of how they do that by way of escorts. Again, it was noted that health system strengthening is important in terms of training, tools, commodities, and equipment. And then the lingering question of partner coordination came up, which needs to be looked into for any form of implementation. The fourth presentation was saving lives through the first 100 days, and with a twist of a video, which really brought out the importance of minimizing loss opportunities by using all forms of entry points for clients and use of integrated tools for monitoring. Then Lydia gave us a presentation on the social map, which to me was really a highlight of the private-public partnerships that need to be there, and the role of the engaging communities in implementing HIV and RS services. The last presentation, which was multi-country, questioning whether or not the HMIS tools that we have are tracking what we're doing, and it was clear that it's necessary to interrogate whether or not the indicators are answering our questions. The key indicators, like unintended pregnancies, were actually missing from the 5 countries that were studied. And the conclusion is that programs need to relook at the tools that they have. I think one other thing that was missing was that programs are not able to tell the active load of patients and retention in care for whatever they're doing. So with that, I hope you can ask your question. The lady there first.